I'm going to invite both speakers to join us on the stage here to open discussion, floor discussion, and to conclude about our session.
We should have an informed consent. There is no universal consent for all countries. Secondly, should we have a consent for the minor operations like the major operations like the life-saving measures? That's one point of view. The other point of view, from the medico-legal point of view, for instance, I once asked a father to sign a consent for his kid who was going to do tonsillectomy. So the consent, what was written in, I agreed to do the operation, and I've been informed about the risks of anesthesia and surgery. So the father told me, I'm signing the death certificate of my son. I won't sign it. That's one point. The other point, there was a female, 40 years old. She had 5 kids. In the meantime, she was subject to bisalpinx or hydrosalpinx in one tube. During exploration, she had 5 kids at that time. The surgeon decided to do hysterectomy for her own sake to save her being subjected to anesthesia a second time. During that time, her mother was present, her husband was present, and they both signed the consent. When she recovered, and she's read that she's done hysterectomy, she sued us. And she said, it's my uterus and not my mother's, not my father. And she gave ideas that have never been raised to our minds. She said, if my husband divorced me and I'm going to be married to a second husband, and I want to have a kid, if my kids died in an operation. So what's your opinion about the consent? Because it's something of utmost importance, and we'd like to have an informed consent suitable for all cases. In the meantime, universal.
To conclude the core of the question, please, in few words. What's the core of the question? What you want from Professor Jeffrey and Dr. Hisham Hosni to answer? We are talking about clinical research and the gap between clinical research of researchers conducted and the practicing our research, our data from the research. Please conclude the question to be answered.
Yeah, the question is to Dr. Jeffrey. I
think he's
what's
not a
your
clinician,
opinion about the
Nabil.
consent? Should we have a written consent, or could you give us a written consent suitable for all cases?
Okay, Dr. Jeffrey, please.
So I think there's 2 ways to address this type of question. One is what we're talking about related to informed consent. One is about the kind of informed consent, so I want to differentiate the two. The informed consent I was particularly referring to is by enrolling participants in certain research. That's the informed consent that's absolutely necessary. There are a lot of standardized forms for a variety of different study designs and different conditions for that type of purpose. Now, a different type of consent, for example, for surgical procedures is something that will be evaluated more on a case-by-case basis. From a publisher's perspective, that's something that we'll generally try to stay clear of, because that's something that probably has to be addressed at a much more legal level. But I would imagine the WHO would probably be a good resource to try to identify what would be the most valuable different informed consent forms. But as you mentioned, there are always exceptions. About the case about the woman who was under anesthesia and the husband signed a consent form and then she sued. There are going to be outliers, and there are going to be exceptions to the rule. We cannot try to cover every single case, and those individual ones will need to be evaluated probably from a legal point of view on a case-by-case basis. But the WHO is doing their best to try to at least have international guidelines and standards for informed consent, not only for clinical practice, but of course also for participation in research as well. It's not perfect yet, but hopefully we'll be getting there in the near future.
Thank you very much. Thanks.
Dr. Dawlatli.
Thank you very much for the presentations. Dr. Robbins, regarding retraction of articles from literatures, the most common 2 reasons for retraction, as far as I know, is the lack of submission of ethics committee approval letters, and the second thing is the sampling and randomization problems. So in order to overcome this, there is so many authors nowadays, statisticians, they are looking into articles. I think I discussed with you this yesterday, and they are using what's called the Monte Carlo simulation score. And based on that score from Britain, there is an author called, I think, Carl Leslie. He's using this, and so many articles nowadays are going to be retracted or already retracted, as you have exactly pointed out. So I think we have to stress on the mode of randomization. Randomization is a big headache, and it has to be done properly, in order to avoid the retraction, problem. Thank you.
Definitely. I think it's a very good point that you highlighted in terms of the importance of the statistical analyses. And as he highlighted, some people have started to argue that traditional statistical analyses, inferential statistics, is not the best way to do so. There are many alternative Bayesian statistics has started to become one mode of way people to evaluate the reliability of results, Monte Carlo simulations. And as he mentioned, more and more now people are going back to reevaluate the published literature to now determine, were they actually done properly? Are they in fact reliable? And as he highlighted, this can lead to retraction of those articles. That means, especially now, because we're becoming more and more worried about the robustness, about the sampling, randomization, and statistics, you need to be extra careful to avoid any of these problems. So I'd like to thank you for highlighting that.
Okay, we have time to accept more questions. Dr. Maha, please. تفضل.
Thank you for the very good presentation, Dr. Jeffrey, Dr. Hisham. My question is to Dr. Hisham. What are the suggested ways or methods to overcome the problems with documentation that we have here in Egypt, especially if it's not implemented by the hospital we're working for?
So to start with this, exactly the answer. It has to be implemented.
Yes.
There's no other way other than documentation. Through their experience, well, definitely paperwork documentation is troublesome, time-consuming. Another issue which is like more advanced is having electronic documentation of every single item that happens to the patient. Every single drug which is given to a patient in the anesthetic theaters or in ITUs should be documented and signed for beforehand, before even having this done, having given to the patient already. But otherwise, there's no other issue except documentation.
I mean, is it worth to implement such a way in our department if it's not applied or implemented by the whole hospital itself?
It will come from the, coming from an academic background, and we are very much concerned about research and about collecting data. This is our only way of collecting data. There is no other way to keep our records except documenting them once they occur. And then we can go for like RCTs or doing observational studies or retrospective studies, whatever. But at the end of it, we should have data just to start doing research and to start improve our practice. We have to believe in it. We have to, once we be more in control, and we have to force this practice into our clinical practice. There's no other way.
Okay. Thank you.
Thank you.
Do I have a time for another question
Yes,
to Dr.
we have
Jeff?
time. Still we have
Okay.
time, please.
Okay. Dr. Jeff, I would like to ask you, in review of the funding problems we might be having here in our developing countries, how do you see the robustness and the research going, and how to gain this confidence or this trust from the journal editors having such problems related to funding?
Of course, that's a great question. There are going to be problems with funding. Is it really fair for a hospital here in Egypt to be compared with a hospital in UK? Because the resources, the funding available are going to be phenomenally different. Journal editors are not meant to be regionally biased, mean they're not going to negatively or try not to negatively see you because you're from an emerging market, but also on the reverse, they won't give you a handicap or a benefit of the doubt because you're an emerging market. To be unbiased means you need to compare both levels equally, and that's what journal editors want to do. So that means you have a struggle, you have a challenge you need to overcome. The best way to do so, one single word, collaborations. If you know you're going to have difficulty with conducting a certain study because of lack of resources, funding, expertise, etc., the best way to overcome this is to find those groups that do. For example, I show there's 21 RCTs from Egypt that I evaluated. Actually, I ended up excluding 5 of them because the key investigators were actually from the US or the UK, but they were evaluating their drugs within an Egyptian population. So likely there was collaborations between the Egyptian hospitals and the researchers, the investigators in other countries. They're going to bring with them their funding. They'll bring with them their resources that you can utilize. And a key benefit, especially as you're trying to establish yourself with these key medical journals, maybe if you are collaborating with a really predominant research group, maybe in Cambridge or in US or in Australia, and you may find it's easier to get published because you're being co-published with these authors. Well, by that time now, you have made your name recognition available to that journal editor. So the next time you submit without those international collaborators, and they look at your name in their submission system, they will see, oh, yes, he or she has already published in my journal, already going to have a positive first impression, and be less likely to have this potential regional bias. So I think collaborations is the best way to go, and at least as you're trying to get established to these international standards, it probably be the easiest way as well. Thank you.
Thank you.
Thank you. Any more questions? Dr. Nabil? تفضل.
Concerning Dr. Sham, please, you've spoken about auditing. Our target, all of us, is the first target is safety of the patient. There's no auditing concerning the mishaps that occur, whether class A or class C mishap. So that will offer safety more to the patient. For instance, in the States, in the aircrafts, whenever an accident occurs, there is an accident investigation team in which the pilot sits in front of them and says the facts, all the facts. And he could never be sued for these facts. In front of the legal authorities, he can change his words completely. Why shouldn't we have this concept here in Egypt or universally, so that the anesthesiologists, even unnominated, they send, in the UK for instance, they send at the end of the year, you've got one book, all the mishaps that occur to avoid them furtherly. So why shouldn't we change our concept, or what's your opinion concerning this item?
Well, concerning this item, exactly, as you said, it is a mandate now, is to have this audit process. It's already spreading into the culture of our hospitals that we have a quality control departments, one way or the, whether they are functioning or not, or for how far they are and they're doing their job. Incident reports are written in several hospitals at the moment. They are reviewed monthly, and we have a kind of a monthly clinical governance meeting. That in this meeting we show how many clinical incidents that we had, how much of these incidents were minor, moderate, or serious. For example, while treating the drug errors, for example, for especially in anesthetics and the ITU, every single drug that should be given to a patient should be inspected by 2 persons, and they should sign for it. And this, really, I find it myself very useful in like the look-alike ampoules and vials, and having someone who might not be in the very best day of that week, but having someone else to revise every single thing about what's in the ampoule and the expiry date really decreased this incidence of drug mishaps.
Thank you very much.
Thank you. Now we are coming to the end of this session. Anyone? Who? سارة تفضل. ولا مين؟
Hello, my name is Michael Hüpfler. I'm coming from Vienna, Austria. And we talked quite a lot about bias. And so my question is, my concern is, are our guidelines so robust, or as they are driven from some countries, do we miss experiences of other countries that could give us even more robust guidelines? And don't we maybe exclude some important things and important studies because of our guidelines? Are they robust enough for the whole world? Do we miss data? Because I've been in Egypt before, and I always bring very important findings back home, although I'm coming from a quite developed country.
I think that's an absolute excellent question, and it's one that, of course, I have no answer to because I don't think people really are evaluating that. His point is, if we're going to be judging the rest of the world on these international guidelines, that may itself be putting biases worldwide. We may be looking at things from a Western perspective and maybe ignoring important variables that may be true in other regions of the world, which is the majority of the world. I think that's an excellent idea, and I think that standardized guidelines, for example, from those Equator Network, probably should take into account of how clinical practice is being done in a variety of regions, not just those from Western countries. So I think they're not doing that right now. I think that is certainly something important to highlight and bring up. So I'd like to thank you very much for that valuable insight.
Thank you, Dr. Jeffrey. I have only one comment, please. We know that now there is a gap, and we know how to solve this problem and to close this gap. To be more reproducible and more discoverable on the impact about our research, do you think meta-analysis or research review or clinical trial is more evident as a research in the mark of research impact? Which of them we have to be directed?
So her question is related in terms of the types of study designs, which ones may be the best ways to help close the gap between evidence and clinical practice. I would say they actually all work quite hand in hand. You need to do RCTs to evaluate the clinical efficacy of a drug or any intervention. And systematic reviews will depend that there's a number of RCTs that have already been conducted about an intervention. So you cannot have one without the other.
Yeah.
But I think observational studies, surveillance studies to evaluate effectiveness once the drug is being implemented in the clinic also has equal benefit in terms of understanding whether or not this clinical efficacy we saw in this controlled environment translates to effectiveness in clinical practice. So I think they all have their valuable merits and they all support one another.
Thank you. To conclude our session, we know now there is a gap between the research, the conduct of the research and the practice guidelines, and we know how to fill this gap. And we know that it's not a matter of funding of the research or creating something, but it is really the transparency of introducing your data. This is most important and most be reproducible in having impact about our research work in the clinical practice. Thank you, dear speaker.